members of the Deputy Speaker.
Commissioner, please. Yes.
Sir? Sit down.
Your seat. The Right Honorable Speaker, Lagos State House of Assembly, Right Honorable Dr. Mudashiru Adayobasa, Principal Officers of the Assembly, distinguished Honorable Members of the Lagos State House of Assembly, Honorable Commissioner for Health, Professor Bayomi, and of course the Permanent Secretary, Minister of Health, Chairman of Councils, as represented by the executives, Chairman and Secretary of the Vice Chairman Forum, Chairman and Secretaries Forum, Chairman and Secretary Councillors Forum, Chairman and Secretary Supervisors Forum. Gentlemen of the press, you are all welcome to this special interactive session holding today, 23rd of April 2020, in the Assembly chambers to receive blessings, briefings rather, from the Honorable Commissioner for Health and his team on the war so far. The war against COVID has been fierce, it has been very decisive, and Lagos State generally is on the lead as far as our country is concerned. However, we have been inundated with a few observations, and of course, the Right Honorable Speaker did set up a joint committee to see things for ourselves. The committee was out at the isolation centers on Tuesday, and we made some reports to the House in respect of that. It's going to be a largely interactive section. However, I have the liberty and permission of Mr. Speaker to thank the Honorable Commissioner and his team for the Herculean job done so far on behalf of the good people of Lagos State. We thank you for your assiduous delivery on your services, and of course, we hope that when we leave here today, we shall all be better informed and better prepared to continue to prosecute the war. The Clerk of the House, I'm so sorry not to have mentioned you. You recognize, sir. Thank you very much. Honorable Commissioner, you have the floor.
Thank you very much. Honorable Speaker, Deputy Speaker, honorable members of the House, my peers, colleagues, gentlemen. I'm here to give you a background on the state of global biosecurity and why it is that Lagos apparently seems to have been somewhat prepared for COVID. And there are several factors that are responsible for that. But having said that, I think that as prepared as Lagos seems to be, we have some very major challenges that we are experiencing, and we are just at the beginning of this outbreak, and I think the system is already under stress. So let me just give you some global background. First slide. So the WHO, the World Health Organization, has been predicting since 2018 that we were going to experience a global outbreak caused by at least one or perhaps two of these very dangerous pathogens: Crimean Congo hemorrhagic fever, Ebola, Lassa, Corona, Nipah, Rift Valley, or Zika. Since then, we've experienced Ebola, we've experienced Lassa, we've experienced Zika, and coronavirus there in red is the latest. Next slide. There's also a global think tank that believes that they started in 2017, that within the next 5 years, we're going to experience a global catastrophic biological event. They describe this as a severe zoonotic transmission. In other words, a pathogen that comes out of the animal kingdom and spreads through human populations across the globe, causing widespread disaster beyond our collective capacity to contain, thereby creating global insecurity, conflict, and economic collapse. Next slide. On this grid, they have predicted that the most likely of these biological catastrophic events is where that red arrow is, and that red arrow represents an airborne virus that is highly contagious, causes widespread disease, and has a variable degree of fatality. Its impact will be high, and the probability of it happening is also high. Next slide. In the last 10 years, we've seen a dramatic increase in what we call emerging infectious diseases. Emerging infectious diseases are diseases that come from the animal kingdom, and they enter the human population, and we generally have no drugs or treatment or no vaccines, and therefore they cause dramatic impact whenever they occur. Just like we've seen with Ebola, influenza, and dengue, coronavirus is just another one of these EIDs, or emerging infectious diseases. Next slide. There are 5 things happening in Africa generally. We're having a population boom. We're having massive environmental disruption. We are subject to severe climate change. We've got massive rural to urban migration. And we've got sprawling, unplanned megacities. Next slide. It is estimated that in about 50 years, the population of Africa is going to quadruple. We're currently at 1 billion, and it is expected that in 50 years, our population will multiply by 4, reaching 4.2 billion, whereas in blue, you can see that Europe remains flat and in fact declines somewhat. Next slide. The result of this is that Africa is going to be a continent of megacities. Megacities that will face major health, toxicity, and biosecurity threats. Next slide. This map is not clear, but in the center, there is the map of Africa, and you can see that these biosecurity threats cluster around the equator, generally speaking, around West Africa, and Central Africa. So this is the map of Africa. Next slide. In the last 10 years, we have seen what the WHO declares as public health emergencies of international concern. After Zika, we have seen another Ebola outbreak, and now we have seen Corona. Next slide. The problem is, where you have a mega city like this, like Lagos, next slide, and there is high human density per square kilometer, it becomes the perfect breeding ground for any waterborne or any airborne, highly contagious pathogen. Next slide. Much of Lagos State has major slum environments. When we did our slum analysis just after the Ebola outbreak by the Lagos Bureau of Statistics, we had about 60 slums. When we repeated that slum analysis 3 months ago, the number had risen from 60 to 600. That is not surprising, because it is estimated that 3,000 people come into Lagos every day and nobody leaves. So those 3,000 people per day must be going somewhere. Next slide. We also have a major water problem. Our groundwater is heavily polluted with hydrocarbons, with heavy metals, and with sewage coming from nearby residential areas, making it extremely dangerous and unhealthy to use groundwater for our day-to-day living. Next slide. Now, Lagos has experienced several biosecurity threats. In the last 3 years, or 4 years since the Ebola outbreak, we've had avian influenza outbreak confirmed, Lassa fever confirmed, another Lassa fever in 27 confirmed, monkeypox confirmed, another monkeypox outbreak, cholera, you remember last year, and an influenza outbreak. So Lagos is experienced in terms of biological threats. These are major pathogens that can cause severe outbreaks and cause high morbidity and very high fatality. Next slide. This is the map of Sierra Leone, Liberia, and Guinea, where we had the outbreak of Ebola in 2014. And this blue line demonstrates how the Ebola outbreak left Liberia and came to Lagos. And these maps here show how the virus, the Ebola virus, spread very quickly across 3 countries. Next slide. This was the epicenter of the Ebola outbreak in Guinea. And if you can see the time frame here, month by month, there was an outbreak moving very quickly across 3 countries, causing complete collapse, lockdown, high morbidity, with thousands and thousands of people dying from the Ebola outbreak. It lasted for 3 years before it was finally brought under control. Just imagine, we are seeing the same thing now in Nigeria, with epicenters of coronavirus moving very quickly across the many states of Nigeria. Next slide. One of the saddest things that happened during the Ebola outbreak is the death of many of the healthcare professionals. At least 50% of the doctors and nurses in the Ebola outbreak succumbed to Ebola, got sick, and died. And their statistics is there. The same thing is likely to happen in the corona outbreak. We've already seen it happening across the world, and our doctors are already getting sick. Next slide. During the Ebola outbreak, one of the biggest problems was what to do with the dead. Next slide. Now, the Ebola outbreak reached Lagos. Fortunately, it came in a manner that we were able to bring it under control very quickly. It did not have the opportunity to enter our high-density areas. It was confined to very low-density, high-end residential areas of Lagos, and it was quickly identified before it could spread into the general population, and that was how we managed to survive with very low numbers. However, we recognized in 2014 that Lagos was not in a position to contain an outbreak caused by a pathogen as contagious as Ebola, influenza, or now coronavirus. Next slide. The main problem is that our health infrastructure is weak. Next slide. When we look at the situation analysis, next slide, we have about 300 primary healthcare structures, 27 general hospitals, 1 state tertiary hospital, and 1 federal tertiary hospital. and patients are supposed to move from primary health care to general hospitals, and for specialist care, they can go to one of the tertiary academic centers. Next slide. This is not showing very well. You can move on. The problem we have in our primary healthcare structure is that patients should be moving through the primary healthcare system from one to the other. This is a primary healthcare clinic manned by nurses, a primary healthcare center manned by perhaps one doctor, and a flagship, or what we call a comprehensive healthcare, where they have 2 or 3 doctors, an apex nurse. The patients should be moving in this direction, and they should be addressed. Most of their problems should be addressed at primary healthcare level. However, what is happening in reality is that patients are bypassing the primary healthcare structure and going straight to the general hospitals, causing an overburden on the general hospitals and pushing them to the point that they cannot cope. Next slide. Whilst, in fact, if the primary healthcare structure was working, most of the patients would be dealt with in the primary healthcare structure, and you would have very few patients needing to use our already stretched general hospitals. 27 general hospitals is far too small a number of general hospitals for a population of 25 million people. However, if your primary healthcare structure was intact, it would take the burden off the general hospitals. Next slide. There are major problems with our primary healthcare structure. The buildings are not fit for purpose. Manpower is severely limited. There are systemic weaknesses in the infrastructure, and they suffer from power and water shortage. Next slide. The national survey, what they call the National Primary Healthcare Under One Roof Scorecard number 4, was conducted last year, and the Primary Healthcare Agency in Abuja, they go to every state and they assess the state of readiness of the primary healthcare system. The reason I'm talking about the primary healthcare system is because it is at the primary healthcare system where your strength is when you're dealing with a pathogen that is causing an outbreak. In red here is the scorecard of Lagos, and the mark up there is 45%. This indicates that Lagos' primary healthcare structure is very weak. Next slide. When you look at the rest of the country, states in the northeast, north central, and around here are scoring above 60%, and Lagos is on 45%. One of the weakest in the entire country. Next slide. This is some pictures of our primary healthcare structure. Next slide. Many of them are in a very poor state of repair. Next slide. And some of them have severe infrastructural and access problems. Next slide. When we did an analysis, this slide is not projecting well. We looked at the cost of paying the doctors. The actual cost should be about 14 billion. We're only paying 3 billion. When we look at running the facility, the cost is about 14 billion. We're only paying 1.5 billion, and so on. When we add it all up, there's a deficit of 30 billion naira that needs to be injected into the primary healthcare structure to make it effective and robust. Next slide. There is a gap in terms of infrastructure and human resources, as I said, 30 billion, and there is a gap in the insurance scheme of 88 billion. If the insurance scheme is going to support the primary healthcare structure, we need to find a collective amount of money in the region of 100 billion naira to have a robust primary healthcare structure that can withstand an outbreak. Next slide. As a result, we found it necessary, well, this is the general hospital, and this is the infectious disease hospital in Yaba. And you can see from the old infrastructure that this facility is not in a position to be used as a facility to manage hundreds and hundreds of patients presenting with coronavirus. Next slide, please. Therefore, since 2015, Lagos State has recognized that it needed to build a robust biosecurity system, and many things have been happening simultaneously. Next slide. What we have done is we have built a very specialized laboratory. We have been training staff. We have been developing policies that should come to the house sooner than later. Unfortunately, COVID caught up with us, and we've developed biogovernance, and we've been working on infrastructure. However, despite all these activities, we were hit by coronavirus, and even though we're the best prepared state in Nigeria, there are some issues that we are experiencing right now. Next slide. This shows you the absence of adequate laboratory infrastructure in Africa. In the United States, they have 1,356 specialized laboratories that deal with dangerous pathogens. There are none of such type in West Africa except for the one that we have just built in Lagos. BSL-4s are the most dangerous laboratories, are the highest grade laboratories where they keep the most dangerous pathogens in the world. There are 15 in America, 10 in Europe, 3 in India, 3 in Australia, 1 in South Africa, and not a single one anywhere in sub-Saharan Africa. So as far as the BSL-3 is concerned, which is the best next level, it goes BSL-1, BSL-2, 3, and 4. 3 is the highest we have, and Lagos is the only place where there is a BSL-3 in the whole of West Africa. Next slide. This is what the inside of a BSL-3 looks like. The staff have to wear special equipment, and they're operating within a negative pressure environment so that they can be kept safe from the dangerous pathogens like Ebola, Lassa fever, yellow fever, coronavirus, monkeypox. This is the only environment in which you can manage those kinds of pathogens. Next slide. This is the design of the Lagos BSL-3 lab. It was a combination of a collaboration between the Canadian government and the Lagos State government, and it was commissioned in 2018. Next slide. What is peculiar about this laboratory in Yaba, IDH, is that the entire roof is solar paneled, and this laboratory runs off the grid. It has generators as backup, but it is entirely powered by solar panels in view of the fact that we have epileptic power supply in Lagos, and what happens in this laboratory cannot be subject to epileptic electrical supply. Next slide. This was the opening, the handing over from the Governor General of Canada to our former governor, and in the background you see the facility. Next slide. And this was the handing over ceremony. Next slide. It is completely powered by specialized negative pressure ventilation systems, and it's, as I said, it has a biobank, and it is the only type in the country and across West Africa. It is in this facility that we are managing the coronavirus now, and it is in this facility that we've been managing dangerous things like monkeypox, Lassa fever, and Ebola. Next slide. Enter COVID-19. Next slide, please. As a result of what was going on around the world, in January, we launched the Incident Command System, whereby the governor became the incident commander and myself as the commissioner, the deputy incident commander. Next slide. The incident command is a very complex structure that is made up of 9 pillars that are dealing with several aspects of an outbreak control. You're looking at epidemiology, case management, laboratory, point of entry, management coordination, logistics, public awareness, and social mobilization. There are at least 400 people operating inside this Emergency Operation Command, Operation Center. It is a command and control. It kicks in whenever there is an outbreak scenario that threatens the stability and the economic viability of an environment. It is a high complex system that is supported by global partners, and this incident command structure meets on a daily basis to manage the outbreak. Lagos launched this incident command system 1 month before our index case, because we had been observing what was going on around the world, and we knew that sooner than later, Lagos was going to receive an importation of coronavirus. Next slide. This slide just shows you the structure of the incident command system. Next slide. Now, this is what happened. An international traveler enters the country, has contact with somebody else inside the country, in this case a driver or a member of your family. That person goes to their house, infects their wife or their children go to school, infect other kids, or somebody goes to a crowded area like a market and infects several people within the market. And where you have a pathogen that can double every 7 days, it then results in an outbreak. And this is exactly what is happening in Lagos and across the world. Next slide. Now, we are about to see several epicenters on the continent of Africa. Each of these will be emanating from several of the capitals in Africa. And as we have seen on other GIS maps from around the world, these epicenters will be expanding very quickly. Next slide. I'm afraid you can't read this very well, but there are 3 scenarios. The first scenario is that we do not see an active case in Lagos, and we drew up this scenario in January, and of course by February and March we had already started seeing cases. Scenario 2 tells us that we will see a number of cases in Lagos, but our system will be able to contain it, except for complicated cases that require intensive care. Lagos has very weak intensive care capacity within the public sector. It's slightly better in the private sector. And generally across Nigeria, Lagos is by far the best state in terms of intensive care, but certainly very weak compared to international standards. Scenario 3 is where there's a rapidly expanding outbreak in Lagos that causes hundreds to thousands of infections, which quickly overwhelms the infrastructure as we know it, overwhelms our manpower, and causes the economic collapse of the state. If that happens, there will be multiple starburst effect, where people from Lagos will move to other states, and other states will start epicenters. Some of them have Abuja has their own epicenter, Kano has their own epicenter, and eventually it will spread across the country, and in fact it will be exported out of Nigeria, as we've already seen. We had 9 cases of Nigerians export coronavirus back to China. Next slide. There are four scenarios, sorry. The first scenario in red, by week 8, we should have been seeing 39,000 cases of corona in Lagos, and that's the worst case scenario. The best case scenario is in black, where we're seeing about 10,000 cases of coronavirus by week 8 from the beginning of the outbreak. It is difficult to say where Lagos is exactly because our testing capacity is unable to identify precisely how many people in Lagos have contracted the coronavirus. But the data that I will show you shortly will give you an idea of which of those scenarios we're dealing with. Next slide. We've done a lot of work in terms of infrastructure, and I'm sure the committee that went on a tour the other day from Yaba to Bagada to Onikon and Landmark and Luth would have seen the massive infrastructural refurbishment that has been taking place in the last 8 weeks, creating several hundred beds of dedicated isolation under biosecurity containment. Next slide. There's a lot to do. We've been increasing our bed capacity from 40 specialized beds, and we're aiming to get to 1,000. We are almost around 600 now. We need to develop specialist facilities like dialysis, special x-rays, ventilators, laboratories, and intensive care. Next slide. There's a lot of manpower gaps, clinical health care workers, isolation centers, skilled non-clinical staff, and logistics. 80% of outbreak management is logistics, and there's very weak logistics operations currently being experienced by this outbreak. Moving patients around, moving supplies around, moving consumables, and generally testing people in the community and returning the test to the lab. And when you get your results, you need to go and retrieve the patients and bring them to the isolation facilities. We are struggling with a lot of those logistical issues. Next slide. This is the IDH, or the Infectious Disease Hospital. It was earmarked for massive refurbishment in 2020, 2021. We had started with the green area where we developed the specialized laboratory. We had started to refurbish the containment area where you put patients who have dangerous pathogens. And in 2021, we were going to develop an infectious disease specialist center. However, coronavirus came and took us by surprise, and so we've had to accelerate the process of developing the infectious disease hospital at a very rapid rate. And any of you who are able to visit, you will see that the whole of IDH is now a massive construction zone. Next slide. Doesn't project well, so I'll move on to the next slide. Basically, these are isolation units. This picture I took in Liberia, and you can see what a temporary isolation facility looks like. You have massive tents where patients are kept. The doctors are staying in these quarters here. And you have incinerators and crematoriums to deal with the dead, and all your logistics and supply chains are kept in this area. This isolation unit, and we are building some of these in Lagos, can house anywhere between 250 to 1,000 patients at any one time. Next slide. This is some of the rehabilitation going on around our isolation facilities. Next slide. At Yaba, next slide. And this is an example of a ward that has been recently renovated, and this ward is, as we speak, has been filled up completely. Next slide. That's a tent that we built for overflow. We were preparing to see more than the number of beds we could keep in our isolation, in our concrete wards, and so we started to build tents. Now these tents have already been filled up. Next slide. That's an example of what the tents look like. Next slide. This is the inside of a ward, freshly renovated, new beds, toilets, everything, air conditioning, recently concluded in several of our wards at the Infectious Disease Hospital in Yaba. Now, you've all heard about ventilation. About 5% of coronavirus patients will develop severe to critical disease. They will need ventilation, and this is an example of a machine that helps a patient to breathe when the lungs can no longer perform the function of oxygen transfer to the body. Right now, we've been expanding our ventilation capacity. We have about 25, but as we speak, we are yet to get them fully functional for patient use. Any moment from now, we may be able to start ventilating the first few patients. And we've been having patients die because we have not had the capacity to ventilate them. But I believe by this weekend, at least 7 of our ventilators would have been activated for patient use. And there are a few ventilators in the private sector that we have been using for some of our patients. Next slide. Next slide. Those are all pictures of Yaba. Now this is the new infectious disease isolation ward that we have designed. We were in the process of developing its bill of quantities. It's in the budget, and we were getting ready to build this over the next month or two, but coronavirus came ahead of it. This is a specially designed facility with cross ventilation, which is the necessary kind of ambience that is required for highly contagious diseases. And the way it is designed is that it uses natural ventilation to protect the patients and to ensure that patients in the adjacent rooms and open wards are not contaminated. Next slide. That is a side view of that facility. It is currently being developed, and by donation from some of our, back one slide please. It is going to be developed at the IDH with the support from some of the corporate philanthropic organizations that are supporting the Lagos State COVID-19 response. Next slide. We hear about flattening the curve. All flattening the curve means is that we try to ensure that the number of people that are infected by coronavirus happens over a longer period of time, as opposed to a short period of time in yellow. If we allow the virus to spread quickly across the community, this dotted line represents the threshold of our ability to cope. In the yellow line, or in the yellow graph, you can see that many patients will get unwell and it will exceed our capacity to manage them. Whereas if you flatten the curve, you will see patients over a longer period of time and it still falls below our capacity to cope. Also, there are treatment options that are coming in every week from research happening abroad, and we may be in a position to save lives if we flatten the curve and extend the outbreak so that all these people above the dotted line do not die from a peaked profile. Next slide. Press. What have we done in Lagos? We've launched the incident command system. Next slide. We've established training and rapid response teams across all local government areas. Next slide. We've further upgraded our facilities. Next slide. We've engaged private partners, private sector and community with all the contributions we've been getting from the private sector. We've increased our testing capacity. Next slide. We've managed most of the cases that we know. The idea is that if you identify a positive patient, you remove them from community so that they do not infect others in the environment. That's what's called containment and contact tracing. Next slide. We've imposed a lockdown. The lockdown is supposed to slow the transmission of the virus from people to people through the process of social distancing. Next slide. Now, the red line demonstrates what would have happened had we not imposed all these strategies that we have done in Lagos. And the blue line indeed is our line. But the red line is what you have been seeing in Europe and America. And had we not been pre-armed, pre-warned, and pre-prepared, we would have gone along the red line. So far, we are on the blue line. But as I'm about to show you, that blue line is beginning to show some very disturbing data. Next slide. This was 4 weeks ago, or 3 weeks ago, 1st of April. These were our numbers. We were diagnosing about 10 a day, and the projection by our modeling was going to go in that direction. Next slide. The next week, we seemed to have reduced the number of cases we were diagnosing per day, which seemed to be flattening the curve. Next slide. But by last week, the numbers started to increase again. And now you see that the curve is going back up. Remember, we're doing much better than Europe and America. Their curve is somewhere up here. So while our curve is relatively flat compared to the United States and Europe that are up here, we are still showing a dangerous trend at the moment. Next slide. As of the last few days, remember 3 weeks ago we were diagnosing 10 per day, then it went to 20, then 25. Now we are diagnosing on average between 50 and 100 every single day. And as you can see, the curve is beginning to rise. Next slide. This place is not projecting well, but essentially it reflects the data on our active community search. What we've been doing now is going from house to house, looking for people who are exhibiting symptoms that could fit with COVID-19. We found some dangerous data or worrying data, which suggests that in places like Alimosho and Koshofe, even Badagry, there were patients who were demonstrating features that could be in keeping with COVID-19. However, remember, COVID-19 is not the only cause of respiratory tract infection. In fact, most of the respiratory tract infection is not caused by COVID-19. However, COVID-19 is a highly contagious virus, and it is in season, and therefore we expect that more and more people will be infected with COVID-19. Next slide. Again, this slide doesn't project well, but you can see that the majority of the cases are in the Lagos mainland, over there, in Ikeja and Etiosa. But we're seeing some worrying activity in Alimosho, Koshofe, and I can't read the rest of the slide. But these slow numbers of increasing cases that we're seeing in our very highly densely populated local governments is cause for some concern. Next slide. This graph is old, from last week, where we imposed active community search and lockdown. Next slide. And as you can see, from the moment we introduced lockdown, it has really not seemed to affect the number of new cases that we're seeing on a day-to-day basis. And this is the current trajectory of COVID-19 in Lagos. Next slide. So we believe that what we're seeing in the hospitals is just the tip of the iceberg, and that there is a very large number of people in Lagos that have been affected by COVID-19. One of the problems with COVID-19 is that about 80% of patients are asymptomatic, which means that you may have COVID-19 and not even know that you're infected, and as a result of that, you will be spreading it because you are not unwell. About 10 to 15% will become unwell, and 5% will become critically unwell. Next slide. So what we've done here, and it doesn't show well, I'm sorry, is we are seeing about 71 cases per day now. COVID-19 is supposed to have a doubling time every 7 days, so we expect that by this time next week, we're going to be seeing over 100 cases per day. And by the third week, we should be hitting about 200 cases per day, and so on and so forth. As of yesterday, we diagnosed 74 last night. And I have a backlog of about 800 samples to test today, and I imagine that I'm going to get over 100 more cases this evening. Next slide. This is a slide showing our increased testing capacity from about the last few weeks. This was last week. We went up from 40 tests per day to, 2 weeks ago, to last week we were performing 1,400 tests a day. Our laboratories are running 3 shifts, 24/7. A shift starts in the morning, finishes by mid-afternoon. A new shift starts at mid-afternoon, finishes in the evening. And a new shift starts in the evening and runs till the morning. That's the only way in which we can ramp up our testing capacity. Next slide. This just shows you that out of all the people that were admitted in Lagos, 95% of them have been discharged, 95 have been discharged, and we have 264 active cases and 14 deaths. Next slide. I can't read this slide well, but this slide shows that majority of the cases are mild, moderate, and in green, you have the severe complications that require high care, ventilation, or kidney dialysis. Next slide. This slide was prepared 2 days ago, and it shows you our bed space at Yaba, Luth, and Onikon. And it shows you the percentage occupancy, 43% at Yaba, 37% at Luth, and 36% at Onikon, making an overall occupancy of about 40%. That was 2 days ago. As of today, by tonight, there will be 100% occupancy. We have just commissioned a new isolation ward at Oniru, the landmark, and we're about to open Bagada, which will give us a little bit more bed space. And we have just opened a hotel in Lekki to increase our bed space. But at the rate at which we are diagnosing corona, even those facilities will be fully occupied by the end of the next week or 2. Next slide. This graph is the most important graph. This line is our isolation capacity. And this graph is the trend of diagnosis. Where we hit the blue line will be the limit of our capacity. And it is projected, and this was projected 3 days ago, that we will hit the limit of our capacity in 2 weeks. However, the speed at which we're making new diagnoses, it seems we're going to hit that capacity in about 7 to 10 days, which means that we need to change our strategy. Next slide. This slide just shows the number of isolation centers. This is Yaba, Luth, Bagada, Lagos, Onikon, and Landmark. Next slide. Critical care. About 5% of COVID cases develop severe respiratory symptoms and sometimes kidney failure. That requires what we call high care in critical care units. Next slide. And if we look at the capacity for Lagos to deliver high care, Lagos here is by far the best endowed state to deliver high care. We have about 40 intensive care beds and about 35 ventilators. But if we carry on at the rate at which we are going, it is possible that we may need to deliver high care to about 3,500 patients in the next 2 months. Not all at once, but over the next 2 months. Therefore, we have a significant deficiency of our capacity to deliver high care to the patients that are going to develop severe complications from COVID. Who are the risk? Who is at risk? We've already been doing an analysis of the patients that have died from COVID, and the risks are anybody over the age of 50, anybody with diabetes, anybody with hypertension, or anybody with any underlying disease that interferes with their immune integrity, or anybody that is showing what we describe as the metabolic syndrome. That is overweight with inability to manage their sugar profile properly. It appears the virus has a predilection for age, for metabolic syndrome, and for anybody with underlying respiratory or immune disorders. Next slide. Press again, again, and again, and again. Okay. So, this slide shows what we have to do as we start to see cumulative numbers of COVID confirmed cases. At this point here, we are just about to cross over from yellow to this area here, where we have to convert hotels and general hospitals into isolation facilities. So we're just about to exceed our isolation capacity, and we need to recruit more buildings into and convert them into isolation facilities. In light blue, we need to recruit the support of the private sector. And if we exceed a cumulative number of 2,000, there needs to be a dramatic change in our policy. And that dramatic change will be either to recruit very large numbers of hotels or IDP camps or schools. The problem with that is we don't have the human resources to manage thousands and thousands of patients with COVID that have been institutionalized. Probably the best bet is for us to change from hospital-based care to home-based care. In other words, we will keep most patients at home, and through our primary healthcare structures, we will manage people by home visitations or by telemedicine or by telephone, cell phones, and we will change our isolation units into high care units, which means if you have mild to moderate disease, you'll be kept at home and you'll be visited either personally or through telemedicine, and we've just launched our Eco Telemed project So people at home can reach doctors through their cell phone, and they can take a consultation, and we can send medication to them. And those with severe to critical disease will be the patients that we will bring to our isolation wards. So the isolation wards will no longer be used for every positive case. We will divide the corona cases into mild to moderate. They will be kept at home in isolation in their homes, and they will be consulted by home visitations or telemedicine. Those who develop severe to critical complications are the patients that we will bring into our isolation facilities. We're still building more isolation facilities, and we hope to go to a position of over 1,000 isolation beds, but they will be mainly dedicated to patients that are extremely unwell from COVID-19. Next slide. Well, this slide just tells us what the state responsibilities are. The state responsibility is to preempt and to prevent a biosecurity threat, to be able to predict, to mitigate and adapt to insidious, unavoidable environmental damage, to find and clearly identify a threat when it emerges, and to stop it promptly. That is our responsibility to the people of Lagos. To do that, we must ensure that we restore calm and we avoid civil disruption and build resilience. It requires operational systems, policies and regulations, legislation to deter threats and enable a rapid scale-up, which is required for emergency preparedness during such situations. A well-trained workforce is required. The role of the primary, secondary, and tertiary facilities is clearly outlined. We need sophisticated laboratories. We need an environmental and public health system. We need to be able to monitor through sophisticated surveillance systems and an emergency response system that is inclusive of law enforcement. Above all, we need a very well-informed population. Next slide. And I thank you for your attention, and I'm happy to take questions.
Yeah, distinguished colleagues, honorable commissioners, local government officials from the chairman to the councillors. I want to say good afternoon and thank you for coming. Honorable Commissioner, I think I have to adjust this. Well, we want to thank you for all you have said and to commend you and through you to Mr. Governor and the rest of the team. Well, from all you have said, starting from those items I've been able to itemize, you emphasize the weakness in our health system, particularly the primary health system. And you also talked about lack of adequate laboratories. I mean, those ones that meet up with the world standard. And your plans, as from next week, if you have started already, going from house to house, and your fear about rising cases of infected people from 100 to 200, if I'm right. Yeah, thank you. Well, in addressing these, I particularly have my reservation, having commended you and your team from what you have been doing. And I would like to take you back a bit. We have just, finished with 2 weeks lockdown, which essence was to prevent people from moving from one place to another. But if we look at these, most especially these, our states, and by extension, local governments by local government, from my own observation, I realized that the lockdown, most especially in some local government, was not observed. Observed in the sense that the nature of structures that are available in all these local governments are not encouraging to observe lockdown. If you have the kind of knowledge I have relating to my own local government and some neighboring local government, where we have more than enough people living in the same building. So you quite agree with me that there's no way such restriction can be carried out. The only thing we have seen, or what happened during the lockdown, was to reduce the number of vehicles on the road. But people were still moving from one place to another. And by so doing, to me, it seems the lockdown did not help our situation. So from there, what do we do next is the question. Analyzing the lockdown, I think we should have results after the first 2 weeks. Results in the sense that, okay, we've been able, with the lockdown, we've been able to identify, though you made mention some local government through your own data. I don't know how you come about your data, that in some areas, LSHA is now going out of hand. You mentioned mainland, you mentioned Etiosa. Fine. What is the participation of local governments in all this? Because for me, I think we should be able to domesticate our efforts in reducing the spread of this virus. Because you have just allayed your fears that from next week, there will be increase from 100 to 200. Probably it will continue to increase. So the state, why the state has taken laudable steps to control this or to arrest it. So what role are we giving to local government officials? Because if you want to get this done, and if you look at it where you talk about logistics, it's very glaring that we are helpless, very, very helpless. There's no way we can have or get enough logistics to battle this virus. But we must take advantage of our own structure. Take advantage of our own structure in the sense that the local government officials must be put on their toes to also participate in this effort. And that is to train the officials and to allow the officials to also go around and make sure the tests we are talking about are being carried out by the local government officials and their various local government. So this will accelerate, efforts to identify those who have been infected. And by so doing, we'll be able to prevent the spread of this virus in all local government. We mentioned it as we mentioned mainland. What have we done in such local government that we have mentioned? How have we been able to identify those who have gotten in touch with those infected already? I think these are the things we should be talking about and direction that we should be going now. But centralizing everything at the state level, I'm not saying you are not relating with the local government official, but how are we monitoring the efforts of the local government official? What training have we given to their personnel to also get involved in this? And what are the results if we have monitored what they are doing? As you have set up a committee, how do you call your committee, which Mr. Governor is the chairman, incident commanders? I think such should be replicated at local governments, where you have the chairman and other necessary personnel, so that if we continue in the manner we are going, we appreciate what you have been doing, and I want to be sincere that you have done enough, but we must move away from centralizing all efforts at the state level also to local government. And that is why we have invited the local government officials to be part of this briefing. So, because after you, we still allow them to share their own experience and what they think they can do in support of the state's effort. So we as lawmakers, we are here also to be of help where necessary. If you have to do something urgently, we will do that. And the one we have done, we will continue to monitor. Now for almost 2-3 weeks, we have allowed you to manage this situation. Now we want to know how far you have gone. For me, and I will allow my colleagues also to make inputs, because if I have allowed you for almost 1 month, and yet there is increase in what we are trying to prefer, I think we need to do more. So we cannot equate, the rising numbers here with that of Europe or America. There's no way we can do that. We might have certain advantage over them as it has to do with this virus, but we don't have the capacity they have. So we must not allow it to degenerate to that level. We must not. And also, we talk about laboratory. I think we can always call back to this, but these are belated issues. There are things that we ought to have put in place. We have laws that talk about this. We have so many things in place, but we can always come back to this. But now, how can we arrest this situation is the major thing we should talk about. We thank you for, briefing us, giving us the genesis up to this period. We appreciate that and how we've been able to handle it in other climes. But now, our major concern is how do we go about it by arresting this virus. So on this, I would like to throw it open for my colleagues before we call on the officials of local government to make their own input. I can see lights. Honorable Oshun.
Thank you, Mr. Speaker. Honorable Commissioner, thank you. Well, mine, I've got some suggestions and some questions, clarifications. So I'll quickly run through them. Well, number one, I actually want to commend your team for your daily briefing. I think it's a nice one, and I think we need to improve more on that. The daily briefing done by your team and the governor, please, I think we need to do that more. Secondly, sir, looking at the way it's rising, and whether we like it or not, it will rise, from my own opinion. But in a place like UK, 80% of the hospitals has been closed down to other ailment or treatments. If you go to all the hospitals in London today, except you are a coronavirus patient, they will ask you to go back home and somebody will talk to you on the phone, unless it's critical. Most of their operations, surgeries has been cancelled, unless it's life-threatening. Don't you think we need to go to that level? We still have lawsuits still treating every other patient. Now, this is something that is life-threatening. So I think we need to start looking at that level. Today in UK, unless it's life-threatening, unless it's an emergency, no hospital will take you apart from the fact unless you're a coronavirus patient. That's one thing I think we need to look at. This coronavirus, this is a question, sir. Is it possible for you to be infected and in the course of maybe taking some things, it treats itself and it goes, you don't even know? Because I've seen a case where somebody said it was assumed to have been infected by coronavirus, but after 3-4 days, the symptoms were not there. So is it possible? And if you are infected and treated, is it possible for you to be reinfected? That's number one. Sir, we keep talking about social distancing in Africa. I think we need to look at our own peculiarity. Social distancing is for the Western world. My own opinion, sir. Either we like it or not, I'm from Lagos mainland. And we have houses where you have 8, 10 people sleeping in one room. In one room. If you go to Bariga, if you go to Ebutemeta, you have buildings. We call them face me, I face you. And you have a family of 7, 8, 10 living in one room. They will wait till 9, 10 o'clock, bring out their furniture, and they will lay their mats on the floor and sleep. And we are talking of social distancing. Social distancing in the UK, yes, it's possible. You have a family of 3 or 4 in a 3-bedroom flat. So when someone is infected, they will tell you to isolate in a room, not coming out to infect others. But in a case where someone is infected here, and he sleeps in a room with 10 other people, how do you isolate that person? So we need to look at this thing because, for me, I think we are just copying social distancing from Europe. But our own peculiarity, looking at our own poverty level, looking at the way we live here, looking at our communal living, is it really our thing? Is it possible? I think we need to look at that. And like the right honorable speaker said, even on the streets, because it's easy. As of today, the size of Costco in London is almost the size of this House of Assembly. But as of today, if you want to shop in Costco, only 5 people is allowed to go in. When they come out, another 5 will go in. So there's a long queue, but they don't care. Yesterday, I went to ICL, Ikeja's shopping mall, and apart from the fact it was not as busy as it used to be, people were moving in and out in what's the name of this store? So I think we need to look at our peculiarity. It's very important. Then, like it's done all over the world, food markets, it's still open. But sir, the food market we have in Lagos, it's running as if there is nothing. And I'll mention 1, 2 for you. Sir, I want you to go to Sabo Market in mainland. I want you to go to Igbo markets. It's running as if there's nothing. People are still in each other's faces. What are we doing? Yes, food is very critical. Food is important. But in as much as it is important, don't we think we are doing more damage by helping our people? What do you think we can be done? And finally, sir, I learned that one of the things we are considering in Lagos is the open system, the day on, day off. Don't you think that will worsen the situation? Thank you very much.
The right honorable colleagues, representatives of the chairman and councillors, the honorable commissioner. I think from a very good fact, we've seen a great job that Lagos State government has done. You mentioned something about flattening the curve. And the reason why you had a good case at the beginning was because you planned ahead of time. It's so obvious and evident right now that the situation is getting out of hand, at least from your presentation. We are right now in what I will call dire straits. The right honorable speaker spoke very correctly when he mentioned the peculiarity of the situation we're at. The way it is right now, where I'm from is Surulere, and we have a very high percentage of senior citizens, talking about people from 60 and above. It is a very serious situation, and I am worried. I happen to be opportune to be one of those who went to inspect the isolation centers, and what I saw became even more worrisome. Before our very eyes, we saw elderly people in cars. They couldn't even get beds yet, and people holding them. So obviously they were infected, and those people holding them had to be infected. We saw ambulances at Onikon where we saw people came in. I mean, I could see almost 8 people immediately coming in. We knew they were infected. The situation is getting out of hands. The people out there do not understand. Honorable Commissioner, the work does not rest with the health ministry alone. Every ministry must put their hands on deck. If you go from Lekki all the way to Shongotedo, you will find a lot of these people begging, putting their hands in cars, like nothing is going on, nothing is happening. Those people can touch your cars, and you want to you come out of your car, you put your hand in the handle, you get infected. And you're wondering how. What is happening? I would like to call you the apex, or rather index commissioner, as this case is concerned, because we're talking about health. I think you need to talk to other ministries and agencies to be able to put their hands on deck. A total lockdown is very imperative. Somewhere like Surulere, it's going to be scary because we don't have those who are immune to this. We must work hand in hand with our chairman into making sure there is a total lockdown for the next 2 weeks to be able to evaluate. Since we found out that these 2 weeks, we cannot say any good improvement. And finally, the workforce, those who work at the hospitals, the frontline workers, what is their plan? We were at IDH, I think that's what it's called, the one at Yaba. The welfare, it's horrible. God forbid anything happens to one doctor. It will affect so many doctors because of the state of where they sit, where they call up rooms and everything. It's clustered, it's together. So we need to start taking these things very seriously if we want to take the situation. Otherwise, God forbid.
Honorable Shao.
Okay, this is better. Listening to your presentation with rapt attention, the first 3 quarters was very interesting, very educating. But when you run into the last part, you have painted a very dire situation. At a point in time, you went into, okay, when we run out of capacity, we will start looking at the private hospitals. When we run out of the private hospitals, we'll start looking at people staying at home. When we run out of that, what is going to happen next? What you have told us here today is that in 2 weeks, 3 weeks' time, there's a big problem, and we cannot manage it. That's what you have that's the impression you've just given me now, that we're in trouble. Because you mentioned that at a point in time, it's going to overshoot the curve. I don't blame you. You're doing a human's job. You're doing your best. I must say that Lagos State has wowed everybody. Lagos State has taken charge. You, the Deputy Incident Commander, the Governor being the Incident Commander. We've done very, very well. But that picture you painted is telling us that we're going to lose this battle. That is exactly what you have told us here. Like Honorable Oshun said, we're here to help. And I want to also say something that I believe might help us. If we cannot slow it down, if we cannot continue to manage what is coming out, because we are locked down now, even though the lockdown might not be the best of lockdowns, the numbers are still going up. Can we find a way to identify and start the isolation earlier? And this brings to 4. I know the state is insisting on the molecular testing. The molecular testing takes time. Yes, it is the best to tell you the viral load and so on and so forth. But as the case is down, knowing that every person we test won't be able to manage them, won't be able to isolate them, can't we go into this rapid testing, whereby if you test people within the community, you now tell them to self-isolate, just like you will still do at the tail end when we run out of space, so that less people will get infected, rather than not sticking to our guns that the molecular test is what we want to do. In 4 weeks' time, it will not matter anymore because our capacity would have been overrun by the number of cases we have. That is the first suggestion I have. Although I know you might say false positive, false negative, things like that, more dangerous. But considering the fact that at the end of the day, we can have a runaway situation, a runaway train with respect to this, can't we consider that so we can start isolating people early enough, at least self-isolation and so on and so forth. The other thing I would like you to address is the issue of what is your suggestion about, if we are going to try and keep flatten the curve, your honest suggestion. People are talking about face masks. By the time we put on face masks, people will be walking around. We're balancing it with poverty, feeding, and so on and so forth. But for you, being an expert in this, what is your own suggestion on what can actually help us to manage this situation, rather than the situation you painted earlier that at the end of this, there's nothing more to do? The third thing I would like you to speak to is, from what you've said now, it's going to get to a stage that the hospitals, general hospitals, will be where people will walk into. First, people will stop calling isolation centers because there's no space there. They will walk into those hospitals when they get sick. What exactly are you doing to protect the medical front respondents in this case at all those hospitals? Bearing in mind, like you said, we lose a lot of people, a lot of medical staff to pandemics like this. What exactly is the state doing to protect them? Because after a while now, there will be the first set of people, and people will come in, they won't know what is wrong with them, and there will be ones that would attend to them. Thank you very much.
Honorable Tony Bravo. No? Thank you. Honorable Strakondi.
Thank you, Mr. Speaker. May I indulge in the existing protocols? Honorable Commissioner, from your presentation, I tried as much as possible to deduce some facts. And one of those facts is that since 2016, WHO has been on the alert that something is going to happen. Pandemic is going to occur since 2016. And does it mean that we don't have any solution, or we don't prepare from that 2016 to now? That's one. Number two, it is disheartening to hear that the public health centers are appalling compared to what we have in private hospitals. My question is this: does it mean that we cannot have some projection towards getting a better public health center?
Honorable Victor, I want you to limit yourself to immediate question.
Okay,
so infrastructure, hospital, or any other thing, that is not subject for today.
Okay, sir.
So just limit yourself to what we're doing.
Let me finally now just ask one very germane question. From the knowledge of science, it is a known fact that when somebody has been treated of a particular ailment, the blood system try as much as possible to produce antibodies against such diseases. Can't we look into the serum system and see if we can deduce a way out so that those people that have already been treated, the blood of the other ones can be used to study the method of trying to lock the virus? Thank you.
Well, I don't, who is that? Okay, Honorable Gundimu. Okay.
Thank you, Right Honorable Speaker. Well, I also stand on the existing protocol. Well, my question has to do with your relationship with the NCDC as to the management of what is happening now. And my second question is very related to that. In your presentation, you did everything with the fact and figure data, everything presented. Even while you were talking about the primary healthcare services and the general hospitals, you made us to know the financing gap that is missing, right? But now, as we are now, you started projecting more what is about to happen, what you are about to do, and the rest. You did not really attach any cost implication to all these things. That is what you have done now. Are we getting the financing of everything from the NCDC, or we are having it directly from the state? And in the expansion of the facilities you have projected, right, you know, maybe in the next 10 days, right, where are those finances coming from? Thank you.
Honorable Togo.
Thank you, Mr. Right Honorable Speaker. Well, sincerely, I want to appreciate you for making this to happen. And I want to appreciate the Commissioner for coming up with the fact. I'm afraid, sincerely, because of so many things that you raised in the course of your presentation. One, you said the isolation, the already launched isolation center were filled, even the overflow. So you make us to realize in the next 2 weeks, there may be no more space. And you now postulate hospital home based rather than hospital based. My question is, do we have enough trained personnel that can handle home base? Secondly, don't you think it will give room for spread of this virus? If we are isolating them and we are getting to this so bad extent, and we now want to confine them to their homes, where their families, their children will have access to them. I'm afraid. Secondly, you will need us to realize that the critical care center do not have that capability to handle the mop-up. And the question that now comes to my mind is, in the last 3 weeks that we've locked down, why is it that the ventilators that belongs to government were not working till today? And you said in the next 2-3 days, they will start working. If they cannot work for 3 weeks, I'm afraid, what will happen after that 3 weeks, 2 weeks? That means endlessly. I don't know. Then you equally told us that, that the primary health care center...
Honorable Tomo, he said they have been refurbished. They are now working. So he didn't say they are not working.
Maybe we have... He said... Okay, sir. Okay, sir. He told us that the primary health care centers were supposed to be the one that will be handling this thing, but we have a very weak primary care health center that we were expected to have spent about 14 billion to make the primary health care center more stronger and more functional. Rather, that we are spending 3 billion, that we have spent 3 billion. So what do we do to make this primary health care center functional, strong, so as to address these problems? Because if care is not taken, it's boomerang, I'm afraid, so that we don't experience what we're seeing in those advanced and developed countries. You know, Lagosians, we interface and we interact. Let me just stop there.
Honorable Naim.
Thank you, sir. Right, Honorable Speaker, sir. Honorable Commissioner, fellow colleagues, and representative of the chairman. My first question is this, sir. Like 4 days ago, 3 to 4 days ago, we have what we call the decentralization. You can't hear me?
You can hear you. Go ahead. Go ahead.
Okay. Like 3 to 4 days ago, we heard about the decentralization of these testing sampling in some local governments. And intelligence reports have it that up till now, they don't have anything like materials to use for that sampling in the local governments now that it's just decentralized. That is one. Two, I want to say that in rural areas, they don't believe that this COVID-19 exists at all. So I don't know the kind of communication you are communicating to them. I think you need to employ these traditional rulers in some local government because they don't believe that this COVID-19 exists. And I want to suggest that probably if you can have a motorized vehicle that could move around like a campaign to talk to our people that this COVID-19 truly exists, because I don't think they, because recently I went to somewhere in Ajegunle and I see a lot of people walking up and down as if there's nothing happening in this country. That is two. Three, I want to say that I have another intelligence report that recently there is a patient that called from Ikoyi that said that they should come and pick him up that is having this kind of symptoms. And when they send a vehicle to them to go and pick the person up, on getting to that spot, they said some people living in that vicinity, they have to come down to come and deflate the tire of that particular vehicle that came to pick up that patient. And they said doesn't want to go with that government vehicle, that he prefer to go with his own personal vehicle. So they said it took the intervention of the chairman of Ikoyi Urban LCDA to come around before they could release the vehicle. So what are you doing in response to this to make sure that those people that are going around to pick this patient are secured? I want to stop there for now. Thank you.
Yeah, Honorable Tebita Pajo.
Thank you, Right Honorable Speaker, fellow colleagues, representatives of the chairman. Mr. Commissioner, you're welcome. Firstly, I want to commend the efforts of the executive arm, the governor, as well as yourself and your support team. My questions are very simple and basic. I was part of the people that visited the centers, the isolation centers, and to my surprise, one of the centers we went at Landmark, the coordinator said it was created in 2 weeks. It happens to be one of the best I've seen. They had all the equipment, they had the ventilators, they had all the tests, and they said, he mentioned, they take tests and they get the results there. How come none of our primary healthcare centers can actually achieve that in 2 weeks if we have the funding in place? Also, I would like to ask, what is the percentage ratio of the number of tests and the positive results we've gotten? If you have about 800 tests backlog as of the moment, and the result comes out, how many of it comes positive and how many comes negative? Also, what are the most common symptoms for this COVID-19 and the immediate treat at home, rather than have people go to the hospital or to the set centers or the isolation centers? Immediate treat at home treatment you have for the people. Also, my local government shares boundary with Ogun State, and we have about, say, 2 to 3 entry points from other states. The influx, what have you done about the influx of people coming from the other states just because they are neighboring states to Lagos State? Also, we also had the governor say that the use of facial mask is compulsory. To what extent will this reduce the spread of this coronavirus? Thank you.
Yeah, Okla.
Thank you, Mr. Speaker. Honorable colleagues, our august visitors, the chairman, and the commissioner for health. And my concerns are as follows. From the presentation of the honorable commissioner, I want to believe that we have gone a long way. We have tried our best. But in the next 1-2 weeks, from what the picture you painted, it appears is going to be gloomy. Or if you like, we are going to be overwhelmed. And as a panacea into all of this, I want to suggest that if we can make a very good use of the local government, just like this Honorable Speaker said, decentralizing all of our activities up to the local government level. The PHC that you talk about, we can build capacity in our PHCs. We can build capacity in all of the facilities that we have at every local government, thereby localizing, the treatment of all of these COVID-19 patients. Using the word of the speaker, domesticating it. I think it will go a long way helping our situation. Again, we can also call for volunteers in every of our local governments, the doctors, nurses, other health workers, to come and assist the various local governments and do your bit in building capacity in them. So that can go a long way solving our problem. Then 2, what are we doing as a state, even as a country, in providing cure to all of these problems, COVID-19, in terms of maybe research into vaccine or whatever to bring about stoppage to this pestilence called COVID-19. Thank you.
Abisi Yusuf.
Thank you, Mr. Speaker. Fellow colleagues, Chairman of the Council, Honorable Commissioner, thank you very much for your brilliancy in presenting the cases to the House of Assembly. Mr. Speaker, and I have to thank you first, because if you have not emphasized what really happened, you know the time you enacted a law really came from you. And because of your proactiveness, that is what you did before the outbreak of this dreadful disease. Honorable Commissioner, I'm from Alimanso local government, and I'm afraid. I'm afraid in the sense that that place, the lockdown is not being, not at all, it is not even felt there. And you know this is the place that if it should break up from that very place, the whole Lagos State is in trouble. What are your plans for this very thickly populated area? That's number 1. Number 2, we have places where you can convert to isolation center. That is, you don't need to carry people right away from Alimanso and take them to Yaba or Onikan. We have what we call Aji Camp. It belongs to federal government. It's vacant. We can convert that very place to isolation center, and people will be able to attend to that very place, to the place. Now, Honorable Commissioner, sir, then again, the distribution of palliative measure, right, Honorable Speaker, is not helping. The way we distribute this palliative measure to our people, I must confess, it adds more problem than it solves it. The way people carry on, when you see, you put food here, you will see thousands of people that will rush to that very place, and you are emphasizing social distance. How can you maintain that? Then again, the local government, Mr. Speaker, they have a lot of job to do. Presently, they are having their jack. They are not doing capital project now. Nothing is being done now. And we have this dreadful disease. The only time you can complain, you can talk about a capital project is when you are healthy. When you are not healthy, capital projects should go and sleep. So now, we swore divert all our resources to the the protection of this dreadful disease. Thank you very much.
Honorable
Finally, Mr. Speaker, I didn't realize that we were being called according to our heights. Maybe I can respectfully move a motion.
Yeah, it's not your turn.
Okay. I guess I'm the shortest then. Thank you, Mr. Speaker. The principal members, honorable colleagues, the Commissioner for Health, and the Chairman, Secretary, Vice Chairman in the House. Firstly, I'd like to commend the Executive Governor of Lagos State, Mr. Babajide Sanwo-Olu, on his steadfastness with respect to dealing with the situation at hand. Furthermore, I would also like to commend the Honorable Commissioner for Health, Professor Abayomi, for your quick response with respect to handling the situation. Admittedly, in your presentation, there has been a lot of emphasis on a deficit in the public health infrastructure. So we are not going to overflog it anymore. But something struck me in the presentation, which was, I think you called it the incident command organogram or the structure as to the different levels and the different levels of command. And I was a little taken aback that the local government had no place per se with respect to that organogram. And the manner in which our structure in Lagos State or Nigeria as a whole is, the legislatures and the chairmen are the representatives' first responders. When issues happen, we are the first set of people they call to, or call on, or call upon. It is my suggestion that there needs to be an involvement of the local government, because in the event there is a failure of health infrastructure or a deficit of health infrastructure, the only way for the people to get back to you, or rather the chain of command to get to you, would have to be an involvement of the people at the grassroots level. We're talking about the curve, we're talking about the rise and spread, and we want to level the curve. What we have now, without being or sounding like a doctor, or from what we've read, is these are locally contacted diseases now. There's no longer any more imported diseases. So what we're trying to do is to make sure that we're doing a lot of contact tracing in order for us to curb the spread. For us to be able to do this contact spreading, or rather to curb the contact spreading, I believe it is very, very important that this level at the local government are very much involved in this. The trainings, the orientation should go to them, and they must be involved. Secondly, my arm of the, I'm trying to be very pragmatic and realistic about this approach. I don't know how true it is as to whether the 2 weeks, there's been an extension of 2 weeks. Maybe I just don't want to believe there's going to be an extension of 2 weeks. But how practical? Because we are having to balance between an economy and security of the people right now. My fellow colleagues have spoken about the sufferings and the hardship being encountered by our constituents. Maybe more like a prayer. How effective is the face mask in preventing the spread of this pandemic? If it is, it's because we're talking about an extension, a possible extension. I practically don't see this extension going any further without an upsurge from the constituents. I know there's no vaccine at the moment, but I'm hoping and suggesting and proposing as well to that, just maybe, in my positive wishful thinking, that this face mask could be a sort of sojourn for all of us to be able to do it. Thank you, sir.
Honorable Nuri.
Thank you, Honorable Speaker.
all protocol duly observed. I wouldn't like to repeat all my colleagues have said, but Honorable Jimmy said something just now. He said he believed there is no fasting. But another way, as a layman, I believe there is fasting because you are treating some people. You said they are negative today, tomorrow, they are positive today, tomorrow they are negative. I think you are using some drug or so, I don't know, or fasting for them, sir. That is one. What are you using for them? I don't want to know because I'm not a medical doctor. But you can, at least what you are using, maybe, you know, some people, they will go to isolation center for a week or two, they will come out negative. Please, maybe you should work more on this. So that we discongest all this, our center. And the other one is this, please, what can we use for prevention? What can we do apart from the normal one they are doing and distances? And some of our colleagues, even senior colleagues, have spoken about that. That is not working here, Honorable Oshun. He said it. That is not working. Like in Ojuwoye, Mushin, I'm representing from Mushin. And Mushin, if you see Mushin very well, you can see, go to Ojuwoye market, people are moving. There's no way we can work on this. Please, I don't know, maybe you answer that 2 questions. Thank you. Thank you, Mr. Speaker.
Thank you, Mr. Speaker. Honorable colleagues, local government representatives, Honorable Commissioner. Mine is not much. I just want to be clear on some issues. This pandemic we are talking about now, for the treatment, what is the average time for the treatment? The average time, because I know we are discharging. And if we are discharging, how many weeks does it take to treat a patient? How many days? Because you mentioned something about being in trouble in 2 weeks. If we can handle patients accordingly, because I know we are discharging very well, if we can handle them accordingly, I think we should be able to discharge before, the discharge and the coming in of patients should be balanced. But if that is balanced, I don't think we will have any problem with number of patients we will have in our centers. Secondly, at IDH, it's a special hospital for infectious diseases. Now that we've converted that place to coronavirus hospitals, and tuberculosis is also highly infectious, it's dangerous as well. Measles, chickenpox, and others. Lassa and co. So if we now convert that hospital to coronavirus hospitals, those sensitive ailments, we will now send them home, or we are still going to be treating them in that IDH centers. Because of the risk, I don't know the way and manner we are going to manage that. And thirdly, this spread, the pandemic, can it be spread through Naira notes or coins? Thank you.
Well, at this stage, I think before we bombard the commissioner further, I don't know if I should allow the local government officials to now come in, or we allow the commissioner to respond to the questions and comments made by colleagues before we now come in from the position of local government officials. Commissioner, how do you provide? Will you want to go through that first?
Mr. Speaker, I believe I should address the questions first.
Okay. So bear with us, officials of the local government will go back to you. Let us listen to the commissioner. You can go ahead.
Thank you. Thank you very much, Mr. Speaker, and thank you very much for all those very insightful questions. If you recall the beginning of my presentation, I alluded to the fact that we're not dealing with a normal situation. We're dealing with a global biological catastrophic event. By definition, you do not see these events often, but when you do see them, they will overwhelm even the most sophisticated and well-developed economies. I also said that Africa is characterized by an exploding population, massive rural to urban migration, and a plethora of expanding megacities that are characterized by hyperdense, poor irrigation, huge human density, and poor infrastructure. And these environments are highly vulnerable to biological threats, and in themselves constitute a biosecurity threat. I also mentioned that most of the health infrastructures in the low to middle income countries in Africa are characterized by the WHO as extremely weak at all three levels: primary, secondary, and tertiary. It is inevitable that this outbreak is going to cause extensive damage. It has done so in countries that have well-developed infrastructure, well-developed organizational systems, and access to well-endowed human resources and vastly far better bed per population ratios compared to many countries in Africa, and in particular the megacities of Africa. I'll come back to that because I want to address the question that came up several times about the local government. Indeed, most of the response is happening at the local government level. It is not a central response. The response has been decentralized right from the word go. We have replicated the incident command structure at every local government level. We have established what we call rapid response teams. Through the primary healthcare structures, they are the foot soldiers. The response is purely coordinated from the center, but 80 to 90% of the work is carried on at local government level. That is the nature of the organogram. That is the nature of the command and control system. There is an emergency operations center replicated at every local government. And we are using the local government structure, which is why I said the primary healthcare structure is the bedrock of the resistance to an outbreak scenario. Now, if your primary healthcare structure is weak, which it is weak, we know that. We even scored one of the lowest scores in Nigeria. And Nigeria is known to have one of the weakest health infrastructures in the world. Then, as best as our local government primary healthcare structures are responding to this outbreak, there is a limitation to what they can do. There is at least an 80% deficit in manpower at the primary healthcare structure level. I know the capital budget for primary healthcare is 1.9 billion, which is about 1/20th of what it should be if you want to have any reasonable infrastructure that can put up a defense against this outbreak. We are operating at about 1/10 of human resources. It is not a surprise to anybody. Everybody knows what the brain drain is. We are making healthcare professionals who spend 1 or 2 years in Nigeria, and before you know it, they've left the country because the environment is not conducive here for them to remain and to enjoy a career as healthcare professionals, because the infrastructure that they work in is unacceptable, the career pathways do not exist, and the remuneration packages and the respect that healthcare professionals enjoy in other environments does not exist in this country. It is a biosecurity threat. It will affect the entire state, the entire country, and the entire world. What is seemingly saving us right now is that it seems as if young people do not succumb to this infection. Anybody up to the age of 40, I have yet to see a casualty. When we see our patients in the wards, all the young people are relatively well. They have minor ailments, but we're just keeping them there. You have seen some videos of them dancing and singing and living their lives as normal. It is only when people above the age of 40, 50, 60, then it starts to cause problems. Does the lockdown work? I totally agree with most of your comments. Lagos State is not a state that you can either practice lockdown nor can you practice social distancing. It's almost impossible. In certain areas where, as you described, there are 10 to 20 people within a house, how do you practice social distancing when 20 or 30 of those houses are using one ablution facility? How does that work? Lockdown, Lagos Bureau of Statistics tells us that 70% of Lagosians are in the informal sector and they earn their living on a day-to-day basis. So if you lock down the economy, you are introducing a different kind of pandemic, a pandemic of hunger, and a pandemic of insecurity. Is it possible to convert all our hospitals to COVID? COVID is not the only pathogen that is killing Lagosians. If you focus all your attention on COVID, you're going to get high mortality and morbidity from the plethora of other pathogens that we have in our environment. Malaria, salmonella, other viruses, cholera, all of them require treatment. Otherwise, people will die. So if you focus all your attention on COVID, you may save some COVID patients, but you will have other people dying of the other conditions that we've neglected. Regarding the food markets, the attempt was to decentralize the food markets so that we allow people to just travel short distances and also decongest the markets. But as you know, we're creatures of habit. Very difficult to change the practices and the habits of our people. And as you rightly pointed out, the general population don't really care about COVID-19. What they care about is how to make a living, and they believe that COVID-19 is a disease of the elite It was imported by the elites. It started off in the elitist sectors of Lagos, and it is the worry of the elites. That is the feedback that we get. If most young people will catch this virus and survive, then it would seem to us that isolating young people in our isolation facilities could possibly be a waste of our resources. And we should be confining our isolation facilities to people that actually do need help. We do not have a vaccine, and the reason why these dangerous pathogens cause so much havoc and collapse economies and create insecurity and breakdown of the environment is because they are new pathogens. We don't have treatment for them, neither do we have vaccines, and their fatality rates are variably high. So if you have an infection for which you have no drug, for which you have no vaccine, and that infection kills a certain proportion of your community and is highly contagious, then there is very little that we as human beings can do, and it has become abundantly clear that even the most sophisticated parts of the world could not resist this outbreak. So what this infection will do is eventually it will find its way throughout the whole community, and it will cause significant disruption. The younger population will survive, but the older population will, many of them will struggle, and it is in that older population that we are going to see a number of situations where we have to try and rescue people from death. The WHO has been warning for a long time that low to middle income countries need to spend more money on health infrastructure, on developing manpower, and on research and development. Our research and development institutions are almost non-existent, and a very significant part of the response to an outbreak of a pathogen that you know little about is a very robust research strategy. We've been trying to establish clinical trials now for 3 weeks, and the problem is we do not have a culture of clinical trials. We simply don't know how to do it. There was a question around the ventilators. Even if we bought 1,000 ventilators, we don't have the medical expertise of people to man the ventilators. The ventilator cannot work by itself. It requires intensivists, it requires high care ICU nurses, it requires biomedical engineers. We hardly have any of those experts. All of them have left the country. We have about 30 in Lagos, and every one patient that you ventilate requires at least 5 to look after one patient. It's called intensive care, but you can change the name to expensive care because it is extremely expensive, time-consuming, and laborious to look after one patient on intensive care ventilation. Our last patient that everybody knows about, one of the most senior members of the federal government, spent several weeks on a ventilator and consumed the time and resources of several people for 24 hours a day for 2 weeks, and still he did not make it. We talked about finance. The NCDC is just a policy-making body, a federal policy-making, the Nigerian Center for Disease Control. They are also reliant on federal government for funding. They develop policies. They have some human resources that they send out. But essentially, the response to this outbreak is a state response, and it is funded by the state in collaboration with developmental partners, the private sector, corporate industry, and of course, there are some grants that come from the federal government. But the federal government also is responsible for funding 35 other states who are in a much worse situation than Lagos State. I did say that the WHO have been warning of this situation for years and being particularly worried about countries like Nigeria, cities like Lagos, Abidjan, Accra, Addis Ababa, Nairobi, Johannesburg, because of the crowded natures of these African megacities and the poor infrastructure and the minute amounts of money that is dedicated to the health infrastructure sector. We cannot perform magic without resources. We simply do not have the infrastructure, neither do we have the human resources. So the virus, as much as we've tried to hold it back, it will do what it needs to do. And its mission is to infect as many people as it can until it runs out of people to infect. As the virus infects people, it is a phenomenon called herd immunity kicks in. That means that the people generally in that environment will develop a collective immunity towards the virus, and it will run out of victims, and then it will eventually die down. Until the community of Lagos has developed a herd immunity, until most people, once you've been infected, you can't be reinfected under normal circumstances because your immune system would have been primed. So once it has swept through the community, then the community collectively has developed a resistance, and therefore it cannot make another sweep through that same community. It would have run out of victims. However, if you lock down, eventually you have to come out of hiding, and the virus will be waiting for you when you come out of hiding. And then we get what's described as the second, or the third, or the fourth wave. It was characteristic of the flu pandemic. You can try and hide. It's just like going underwater. Eventually, you have to come up for air. And the moment you come up for the air, the virus will be waiting for you. As I said, its mission is to infect as many people as it can, until there is a general community resistance by virtue of your immunity, or unless we can develop a vaccine very quickly, and that is almost an impossible request because the minimum time to develop a vaccine is at least 1 year. Regarding the testing, there are several rapid tests on the market. They range from an accuracy of as low as 30% to somewhere around 70 or 80%. The question is, if you ramp up testing, what are you going to do with your results? If you suddenly give me 1,000 positive cases today, where are we going to put them? As in medicine, we have one golden rule. Do not test for what you cannot manage. If I am unable to treat people for a particular condition, then it is relatively unethical to perform a test for a condition that you cannot manage. So while we're trying to test the people that are showing severe, moderate to severe symptoms so that at least we can try and rescue them, if I carried out mass testing in Lagos, I'm going to have mass positive results. And then I will be forced to find a solution in an environment where I do not have the resources. We talked about building isolation centers in 2 weeks. The isolation center at Landmark, just like the one at Onikon, and the one that's happening at Yaba now, supported by the COVID coalition, has huge amounts of resources thrown at it. Several billion naira with expertise that's drawn from the corporate sector to build such facilities in 2 weeks to cater for 60 or 100 beds. And I just told you that we're diagnosing 100 a day. So if I have 100 new cases every day, I'm going to need one of those isolation centers every day for the next 3 months. So I don't think that that's a feasible option. And certainly the government doesn't have the resources or the wherewithal to do that. Where is the money coming from? Well, I've told you, federal government has given Lagos a small grant of 10 billion. That money has already, in my opinion, been consumed by the Lagos response. Lagos has been spending relatively more than any other state in Nigeria on health, but still it is below the recommended percentage of the GDP. The IGR of the state at the moment is almost flat. All the economies are running on the downward slope. So it is a worry where the state is going to find the resources to carry on the battle against COVID-19. One of our biggest problems is access to drugs, access to reagents. We are testing as fast as we can test. But remember, we don't make anything in Nigeria. Everything is imported. And other countries are consuming the same reagents because the outbreak is all over the world. So we're hustling to get reagents off the market, and the prices have escalated, naturally responding to the economic law of supply and demand. So the demand is in excess of the supply, and therefore the prices have skyrocketed, and we're having difficulty finding reagents. We're finding it difficult to get personal protective equipment for our doctors, and we're finding it difficult to find the drugs that we are trying to use against COVID-19. Right now, there is no established or no known treatment. We're just trying different drug combinations that appear to have some effect. But so far, the WHO has not declared that there is any known drug that is singularly effective against COVID-19. So if the trend continues as I described, we are on the verge of running out of resources. we will need to change our strategy. I think it's invariable or inevitable that we're going to move to home-based care and that we're going to reserve our established facilities for complicated cases. However, within those cadres or within that group of complicated cases, our capacity to deliver intensive care is significantly handicapped. One, by the number of equipment we have, and two, by the human resources that are required to run those equipments, and three, by the experience that is required for you to become an effective intensivist. You need to have spent several years working and studying under supervision in well-established environments where intensive care is part of the culture of medical delivery. We have made a request through the federal government to import medical personnel, and I think you are all well aware of the resistance we got from the associations. We did not start the discussion to import doctors to look after patients. I think we can manage that up to a point, but we're soon going to exceed our capacity in terms of doctors looking after sick patients. But what Lagos was looking for was some key gaps in our medical repertoire. And some of the key gaps we have are intensivists and molecular biologists. The molecular biologists are those that carry out these very complicated tests that are carried out in very sophisticated laboratories. So we have a severe shortage there. And intensive care, we have very, very weak intensive care capacity in this country. So we were looking, if all of a sudden we have 1,000 people that need intensive care, and we only have 30 machines and 30 intensivists, it will then mean that we need to decide who is prioritized to gain access to an intensive care ventilator. And a patient can spend up to 2 or 3 weeks on a ventilator. So if we have 30 patients on our 30 ventilators, and we have 1,000 patients to ventilate, then 30 minus 1,000 are the ones that will not get ventilated. So the problem really is, going back to my first statement, when there is a global biological catastrophic event, nobody escapes, but the countries with the weakest health infrastructure are the countries that are going to suffer the greatest shock and disruption, mortality and morbidity. I think, based on what we're seeing, that for some reason in Lagos and across West Africa, our youth seem to be handling this virus very well. And if that's the case, I believe we may not see many fatalities amongst a certain age group. But what we have to look after are those with the risk, those that we have classified as high risk, and I've already outlined from our experience, from the patients that have died in Lagos, we have a clear idea of what those risks are. And those are the patients that we need to spend some time thinking about how we're going to try and save as many as possible. There's nothing we can do about a highly contagious pathogen that is airborne or droplet-borne, moving very quickly through a community that is characterized by hyperdense living conditions, and poor environmental sanitation. I think I have tried to answer.
Yeah, thank you very much, Honorable Commissioner. Well, you may take your seats. Let us hear from the officials of the local government. Mrs. Essing, where do we start from? You pass the mic, please.
Right, Honorable, sir.
Yeah, sorry, before you go, I want you to speak to what we have said concerning
Yes.
local government
Yes.
and the response of the commissioner.
Permit me to stand by the existing.
Go ahead.
My Honorable Commissioner, we commend the Executive Governor of Lagos State for being proactive and all what you have done. You have really impressed the country, because there are a lot of people who are thinking, I pray I was in Lagos